Hello, my name is Chad Reyes. I'm from MedStar Washington Hospital Center. This is CVI channel on YouTube, and this me is Zach Rosol. He's a second-year fellow from Baylor University Medical Center. Welcome, Zach.
Thank you.
You have an interesting structural case for us.
I do.
I'll let you go.
Appreciate it. Yeah, so thanks for the opportunity to share this case. So this was an unfortunate patient that came to us, and we came up with a very creative solution for her, so I wanted to share that with you guys today. So a little bit of background on her. She's a 51-year-old mother of 3 who presented to us as a 3rd surgical opinion due to class 4 heart failure symptoms that were resulting from her severe aortic regurgitation. A little bit of her HPI. She actually was diagnosed with NASH-induced cirrhosis back in 2014. She had esophageal varices complications for which she underwent a TIPS procedure in 2015, which unfortunately became infected, and she was treated for that, recovered. 2 years later, developed again bacteremia, and unfortunately that's when she had aortic valve endocarditis and vertebral discitis. Treated for long-term antibiotics with that and did clear the infection, but was rendered with the severe heart failure symptoms as a result. So she's been declined by 3 separate surgical institutions in 2 states. As you can see, her STS score is elevated 9.5% because of renal dysfunction and her mostly, her previous surgery and everything. She was evaluated by our liver team with a biopsy, who deemed that she would be a transplant candidate actually if we could deal with her aortic regurgitation. You can see there her child's Pew score was 9. So just aortic, or as we talk about TAVRs here, we remember that all of the approval for them is for aortic stenosis, but here we're talking about an aortic regurgitation case, so just wanted to make that disclaimer. These are her sizing images from her CT scan. As you can see here, her sinus via salva was 34 millimeters. She has an average diameter of 28, her perimeter is 78, and her coronary ostial height were both greater than 10, so all pertinent markers. So the question then becomes, how do we size aortic regurgitation without aortic stenosis? Right. So our strategy, the problem is that she's got a lack of calcium, which is usually used for anchoring of these valves. So what we decided to do, by the sizing chart, she would be sized for a 29 millimeter valve, but we decided to upsize to a 34 millimeter valve to increase the radial force. And then we felt it was really important also for rapid pacing to minimize pop-out and migration during the actual deployment of the valve.
Because during core valve, you don't usually rapid pace, but in this case, you're going to do it.
Exactly, yeah, we felt that was really important. So here are her images, her TE intraoperatively before the implantation of the valve. You can appreciate the severe aortic regurgitation with the flail non-coronary leaflet. So preparation, here's our aortic root shot showing severe aortic regurgitation as well. And our first deployment of the valve, again, we were trying to place that valve as high as possible in order to maximize the radial force provided by the core valve. So I'll let that run through here really quick and you can see where, and I can say our first attempt obviously, and I'll get to our second attempt as to why. Right before we were ready to release the valve actually migrated about 1 centimeter away, and then we had severe regurgitation again, and obviously it was not in a good position. So fortunately with the core valve, we were able to recapture, and we moved our deployment into a deeper position. Here you can see right before the releasing of the valve and the releasing of the valve, the root shot shows there's no regurgitation. You can see there's good flow down the coronary ostia as well. And then here on the right, we have the actual releasing of the valve. So going to her post-op TE, the post-implantation, you can see there's no regurgitation at all, and you can see there's still no obstruction in the coronary ostia, which is great. Just briefly, here's her hemodynamic tracings before and after. You can appreciate in the pre-images, or the pre-tracing, that the aortic diastolic pressure and the LV/EDP converge, and the tracing afterwards, you can see they normalize. There's good separation there. So just a brief follow-up for her. We saw her a month later in our valve clinic. Her symptoms have much improved. She's participating in cardiac rehab. Her ejection fraction is normal, and she's actually undergoing workup for her liver transplant right now. She's been able to go home too.
Great.
So
the only question I have for you, the valve was so deep. Did it affect the mitral valve?
Fortunately, it didn't. we were worried about that, obviously, but for her, just with her anatomy, we were able to get away with it. There was no regurgitation or restriction of the anterior leaflet motion.
Another message here, I see you did it by TEE guidance because it's AI more than AS.
Yep, yeah, and we felt that was really important, just given the lack of calcium as another marker, and along with the rapid pacing, that we really got this in the right position to maximize the amount of force.
Thanks, Zach, for being here. Watch this video and the others on CVI YouTube channel. This is Shadi Reyes from Washington, D.C.